Obsessive compulsive disorder is listed in the DSM-5 under obsessive compulsive and related disorders. Other disorders that are listed in the same category would be obsessive compulsive and related disorders due to another medical condition or due to substance or medication, body dysmorphic disorder, hoarding disorder, trichotillomania, which is a hair pulling disorder, and excoriation, which is a skin picking disorder. Obsessive compulsive disorder was originally categorized under anxiety disorders in the DSM, and that was in 1952. But in the release of the DSM-5 in 2013, it was updated to its own category, which was the obsessive compulsive and related disorders category. And obsessive compulsive and anxiety disorders, they respond to similar treatments and they are often co-occurring. But the change was made due to the fundamental features of OCD being obsession and compulsion, not anxiety. So it's not primarily an anxiety disorder. Those two things are just co-occurring. So the criteria for diagnosis of OCD would be the presence of obsessions, compulsions, or both. The obsessions or compulsions are time-consuming, lasting more than 1 hour per day, or the obsessions or compulsions cause clinically significant distress or impairment in one's social, occupational, or other important areas of functioning.
OCD stands for obsessive compulsive disorder, and this is a psychological condition that involves primarily two kinds of symptoms. You have obsessions, and these are unwanted thoughts or ideas or images. The person doesn't want to have them, they can't stop them from coming to mind, and they create a lot of anxiety and distress and uncertainty for the person. And then compulsions are the things that the person does to try to get rid of the obsessional thought or the associated anxiety, and sometimes these behaviors take on a ritualistic or compulsive quality.
So as somebody who does have OCD, I thought this would be an interesting disorder to do a presentation on, just so I can give some additional insight. So what the guy was talking about with the obsessive thoughts and then the compulsive behaviors that we partake in to keep those thoughts at bay. So that would be, thoughts of your family or yourself coming into harm's way. And then the compulsive behaviors would be little things that you do repetitively in order to ensure their well-being or your own well-being. So when I was a kid, I thought I needed to kiss or hug my mother goodbye every single day before school. And if I didn't, something bad was going to happen to her. So this started with the thoughts of something bad happening to my mother. And then me convincing myself, oh, okay, if I hug and kiss her goodbye every day, I'll keep her safe. And it's not rational, but OCD is not a rational disorder to struggle with. So we just partake in these behaviors in order to keep those obsessive thoughts that we don't want to have from coming true. So we already touched on some of this material at the beginning of the presentation, but how would you decide to diagnose someone with OCD? Well, first, are there obsessions or compulsions interfering with their ability to function? So are they lasting more than an hour per day and they're interfering with their social, their work, school, family, or personal functioning? And if so, you would go and get evaluated by a licensed professional, and they would say, do they have obsessions? Do they have compulsions? Are they time consuming? And do they impair their functioning? And then, of course, you want to make sure that there's not any physical issues that could be causing those symptoms, and that would be done through a physical exam and blood tests. So first, if you have been diagnosed with OCD, you would determine a treatment plan, you would maintain that plan, and hopefully you would achieve relief from the symptoms and in order to regain control over your daily life.
So OCD is not something that can be diagnosed by some sort of medical test, biological blood test, or genetic test, or anything like that. It needs to be diagnosed by an interview with a skilled clinician. And I guess everyone to some extent has some symptoms of OCD. It occurs naturally in the environment on a continuum in the population. And so when the symptoms get to the point where it's getting in the way of functioning or causing a great deal of distress, taking up a great deal of time, that's when a clinician would say, okay, you meet the criteria for having this diagnosis.
So the key to distinguishing the difference between OCD and similar disorders would be, again, the obsessions and compulsions. So somebody with OCD attempts to block or prevent those obsessions and compulsions would cause an increase in their distress. And the distress usually manifests as a high degree of anxiety, which is probably why it was listed under anxiety disorders in the DSM before 2013. There's a lot of anxiety that comes along with this disorder. So, you could have similar symptoms to somebody who has OCD, but have a completely different diagnosis. So like excessive worries. If you just have excessive worries, that could just be generalized anxiety disorder. Like hair pulling and skin picking, that could be the trichotillomania or the excoriation disorder. Impulses could be disruptive impulse control and conduct disorders. So, somebody with OCD could experience all of these symptoms, but the difference is they would have the obsessions, compulsions, and distress when they try to block those obsessions and compulsions.
My name is Kyle. OCD interfered with my life. I lost most of my friends. That was my own fault. I did it. I completely secluded myself off from the world. I wasn't eating, I wasn't sleeping, and I could not work anymore. I had to leave work because I could not focus on anything but my problems.
Obsessive compulsive disorder is a condition that, as the name suggests, is characterized by obsessions and compulsions. Obsessions are intrusive thoughts or images that a person struggles to get out of their mind. And the person deals with the anxiety and the distress that these thoughts or images cause by doing what we call compulsions, which are behaviors or thoughts that are designed to reduce the individual's anxiety or prevent the bad thing that they were worried about from happening. Certainly there are more common compulsions than others. The most common ones are the ones that we think of as the classic examples of OCD. People who will hand wash a very large number of times during the day. People who will check things an excessive number of times, checking the door 50 times while trying to get out of the house, checking the stove excessively, say before bed or before leaving the home. Those are probably some of the most common ones. The obsessions, the thoughts or worries that we're talking about here are not just worries about real life problems like finances or health or relationships. The worries in OCD are usually a little bit more unusual than that.
It affects me on a day-to-day basis of rituals and superstitions. My obsessions were that I would go crazy and harm people or harm myself. And compulsions were to store away anything sharp objects, such as knives, pizza cutters, cheese graters, anything like that.
There are a number of treatment options for OCD. One of the best things people can do is to get better educated about OCD through some of the excellent self-help reading materials that are available. And many people are able to, once they know about what treatment for OCD looks like, to do a very good job of applying that treatment in their own lives without necessarily having professional help. Now, there are cases where professional help is certainly required, especially when the OCD is more severe. And in those cases, making contact with a therapist who has experience with OCD.
Intervention evidence-based obsessive compulsive disorder. OCD relies on both pharmacological and psychological treatments. Serotonin reuptake inhibitors, SRI, and cognitive behavior therapy, CBT, are supported by research evidence and shown to be useful in the treatment of OCD. Cognitive behavioral therapy, or CBT. What is CBT? CBT is based on the idea that how we think, cognition, how we feel, emotion, and how we act, behavior, all interact together. The way we think determines our feeling and our behavior. Therefore, negative and unrealistic thoughts can cause us distress and result in problems. CBT is a practical talking therapy that mainly focuses on the present, focuses specifically on the problem, or focuses on the client and how it's affecting the life. Hard work is required when receiving treatment. Also, CBT is still evolving. CBT evidence-based techniques. CBT uses two techniques to treat OCD. One of them is exposure and response prevention, or ERP. In ERP therapy, people who have OCD are placed in situations where they are exposed to their obsessions and compulsions. It helps to decrease the frequency of these obsessions and compulsions. OCD becomes mild and the situations can be ignored. Sometimes they disappear. The second technique is cognitive therapy, CT. It helps to identify negative behaviors to confront to obsessions by responding in a new way. CT has helped thousands of people. In fact, some studies show that more than 85% who complete a course of CBT experiences reduction in OCD symptoms. Implications for intervention. CBT for obsessions. Psychoeducation explains the meaning of OCD, explains the principles of the treatment, and review clients' understanding. Challenging assumptions is taking the obsession and challenge the logic that underlines the tool stopping terminates the obsession. Distraction is by doing something that demands attention. It helps, or talking to friends and family. CBT for compulsions. Psychoeducation is understanding the problem. Challenging assumptions. Clients need to take the time to appreciate, accept, and articulate their arguments. Exposure and response prevention should not be forced. Self-driven exposure provides support. Some limitations of ERP and CBT techniques. ERP is not effective for many patients. ERP is less acceptable and less effective for OCD patients with overvalued ideation. The overlap of ERP and CBT techniques, even an efficacious treatment, is of limited value if the patient is unable or unwilling to tolerate the demands of treatment. The main reason for failure of CBT includes patients' lack of motivation and reducing rituals and the cost of CBT. Critical thinking. The following statements support the idea that CBT techniques are logical and well-founded. CBT therapists guide the patient through a process of awareness and voluntary effort to learn how to fight and handle the disease. CBT represents a problem-focused approach. CBT presents a logically consistent and compelling relationship between the disorder, the treatment, and the specific outcome. Positive connotations of OCD. Conquering OCD can teach people some valuable lessons. People who get treatment can live more successfully than they did prior to the condition. Negative connotations of OCD. People with the disorder have high levels of anxiety and excessive thoughts. People can experience discrimination caused by the stigma of having a mental disability.